Pericarditis is one of those diseases that isn't really dangerous, but it can certainly masquerade as one, like a STEMI, for example, and in rare instances, become one of the most life-threatening diseases called a cardiac tamponade. My name is Maruf, and in this video, we'll go over pericarditis exactly the way you need to know it for the boards. Let's dive right into it. The heart has a thin, elastic sac around it called a pericardium. Now, the job of that pericardium is going to be to protect the heart and to lubricate it so that when it contracts, it's not getting sheared by all the structures around it, like the lungs, for example. Sometimes a disease process can cause that pericardium to become really inflamed, what we call pericarditis. Now, this pericardial inflammation is usually due to some sort of recent viral infection, like with an enterovirus like Coxsackie or echovirus, but in reality, the list of viruses is vast and really not worth memorizing. I would remember the enterovirus family though. What we see is that the viruses don't necessarily infiltrate the pericardium. Instead, viral infections are going to allow for systemic inflammation throughout the body. That's why you get things like fevers and body aches and headaches whenever you have a virus. And sometimes that diffuse inflammation can also involve the pericardium and cause pericarditis. Now, technically, there's an autoimmune aspect to pericarditis as well, since there are pericardial antigens and proteins that can look very similar to the proteins of that invading virus, and that can cause the body's immune system to accidentally attack its own pericardium. That autoimmune component is actually why people can develop repeated or recurrent episodes of pericarditis, and why colchicine is so important to help prevent this from happening. And we'll talk about that later. Now, while viral-associated inflammation is the most common cause of pericarditis, another etiology that the PANCE likes to bring up from time to time is a recent myocardial infarction. So the dying heart tissue is going to be undergoing significant inflammation over the next few weeks after it undergoes a myocardial infarction. And this inflammation can cascade into the pericardium as well, and we can develop what we call Dressler Syndrome. Now, the remainder of the etiologies for pericarditis is really pages long and fairly low yield for the boards. But maybe just know that you can have things like uric acid infiltration into the pericardium in patients who have like chronic kidney disease, or you can have granulomatous infiltration of the pericardium from sarcoidosis or other autoimmune diseases. Even malignant cells can infiltrate directly into the pericardium and cause an inflammatory response. Again, not really important for you to memorize, but it's good to hear it at least once. When you get this pericardial inflammation, it's going to lead to a pretty classic description of chest pain, which is this sharp pain that gets worse with deep breaths and laying flat, and better with leaning forward. You can imagine that the lungs are pretty much wrapped around the heart, kind of like a hug. So every time the patient takes a deep breath, the lungs squeeze that inflamed pericardium, kind of like a firm bear hug, and it causes that hallmark pleuritic chest pain. Now, for that same reason, patients usually feel worse when they lay flat, since that inflamed pericardium is now sitting right on top of those lungs, but they usually say they feel better when they sit forward, since the heart gets freed from the lungs and there's less of that bear hug effect. Rarely you can hear a scratchy, high-pitched noise from the movements of that inflamed pericardium, and we call that a pericardial friction rub. Now, you'll usually hear this best near the left lower sternal border, especially if that patient sits forward so that the heart sits closer to your stethoscope. Now, in reality, this is a very rare finding, especially in a loud emergency room, but if you hear it, you should immediately think pericarditis. A unique thing about the pericardium is that because it is attached to the epicardium, it has the ability to create injury patterns on EKG in the form of ST elevations, just like in STEMIs. However, while STEMIs involve cardiac damage in a very territorial fashion, in other words, in contiguous leads, pericarditis has damage diffusely throughout the pericardium, and for that reason has ST elevations that will be throughout all the leads on the EKG at the same time. Sometimes that inflamed pericardial tissue can leak fluid into the pericardial sac, creating what's called a pericardial effusion. That effusion is usually pretty small and insignificant, but its presence should lead you towards pericarditis. Now, in a very small percent of these effusions, you can develop a very unstable condition called cardiac tamponade. This is where that effusion starts to exert a squeezing effect on the heart, making it difficult for that heart to actually relax and fill up with blood. This diastolic dysfunction of the heart is going to make it impossible for that heart to receive enough blood and maintain an adequate cardiac output. That patient inevitably will develop hypotension and instability. Now, these patients also develop jugular venous distension from the heart's inability to receive blood and muffled heart sounds from the fluid within the pericardial sac. Now, cardiac tamponade is such a dangerous diagnosis that if you're presented with a patient with this combination of hypotension, jugular venous distension, and muffled heart sounds, then you should immediately assume that this patient has cardiac tamponade, and your next step is automatically an emergent pericardiocentesis. No EKGs, no echoes, no medications, none of that, just right to the needle. Lastly, in a small number of patients with pericarditis, they may develop myocarditis as well from that same inflammatory process that caused that pericardial inflammation. Since these patients now have inflammation of the myocardial layer as well, the heart will actually start to leak troponin enzymes into the bloodstream. Now again, this might make it sound like a STEMI, but we're going to go over how to differentiate them in just a bit. The diagnosis of pericarditis on the PANCE is pretty straightforward. You just need 2 of the 4 features of pericarditis, and that's between the classic chest pain pattern, the diffuse ST elevations on EKG, a pericardial friction rub, and a pericardial effusion. Now, thankfully, most patients with pericarditis on the PANCE will already have that classic chest pain pattern of pleuritic component, better with leaning forward, and worse with laying flat. So as soon as you see this description, you should already think pericarditis as your leading diagnosis. In that case, the easiest way to confirm pericarditis is to get an EKG as your next step. And if you have those diffuse ST elevations, then you've got pericarditis. Now, the EKG might also show PR depressions, but this isn't a requirement for the diagnosis. I just don't want you to be thrown off by it if you see it. It is rare that you'll be able to hear a pericardial friction rub or be able to get a stat echo to find a pericardial effusion, but I would remember that these 2 features are also diagnostic of pericarditis, so if you see them, you should already think pericarditis. Once you've confirmed the diagnosis of pericarditis, the treatment plan is also fairly straightforward. You'll need to place the patient on an NSAID, like ibuprofen or aspirin, to help treat the inflammation that's innate to that disease. Now, you'll usually place the patients on a tapering regimen for a couple of weeks, but you really don't have to worry about all the tapering details. Patients with pericarditis should also be started on colchicine, since colchicine is going to help to prevent relapses of the disease, what we call recurrent pericarditis. This dual therapy is now the standard of care for patients with pericarditis, whereas back in my time, colchicine used to just be optional, but good changes. Lastly, let's take a few minutes to make some important distinctions between pericarditis and an ST elevation MI. I'm sure you've noticed there are a lot of similarities between STEMI and pericarditis because they both cause chest pain, both cause ST elevations, and they can both even cause troponin elevations if that myocardium is involved. In clinical practice, it's usually safer to just err on the side of STEMI since that's going to be the more dangerous diagnosis. But on the boards, they distinguish pericarditis from STEMI in a very black and white way. The best way to differentiate pericarditis from STEMI on the boards is to look at the quality of the patient's chest pain, where patients with pericarditis will have an iconic, pleuritic, and positional chest pain, while patients with STEMI will have a pressure-like discomfort that's usually worsened with exertion. The other major difference between these 2 diseases on the boards is in the pattern of the ST elevations. Remember that patients with STEMIs will have a territorial distribution to their ST elevations, where you'll see them elevated in contiguous leads, whereas in pericarditis, you'll see ST elevations that are more diffuse and haphazard. Sometimes the PANCE will give you a pericarditis-sounding patient, but will also give you a positive troponin. This usually tricks students up because they presume a positive troponin always means ACS, but technically that is not true. Keep in mind that troponin is just a sign of myocardial injury. So you can have troponin elevations with acute coronary syndrome, yes, but it can also be seen with things like myocarditis, where instead you have inflammation of that myocardial tissue that has nothing to do with atherosclerotic disease like an ACS. So don't let the troponins confuse you. Instead, let the type of chest pain and the pattern of ST elevations be the thing that helps you differentiate between STEMI and pericarditis. That just about wraps up our segment on pericarditis as well as our chest pain series for the PANCE. Now, obviously, the most important way for you to consolidate your knowledge is to do practice questions, but more importantly, receive guidance on how to actually approach these questions. So be on the lookout for a link to exactly that. I'll walk you through how to answer these questions in a clean, methodical way. Otherwise, please be sure to like and subscribe so that we can keep this channel growing, and make sure to check out the other videos that tie in with the chest pain series. I'll see you there.